you very much, Dr. Patel. Thank you for the invitation to speak about the frontline treatment of advanced non-small cell lung cancer without actionable driver mutations. And so here in this presentation, I will go over key clinical trials of immunotherapy in advanced non-small cell lung cancer. And as alluded before, this is an ever-evolving landscape. And to summarize the results of the key clinical trials, I think it can be well summarized by this one picture where we show that the immunotherapy-based approach is superior to platinum-based doublet chemotherapy, be it immunotherapy by itself or in combination with chemotherapy. So I'd like to start by showing a patient of mine. I'm still taking care of the patient. Met the patient a few years ago, a 76-year-old male with initially diagnosed stage 3A non-small cell lung cancer based on having two different nodules in different lobes of the left lung back in 2015. And he underwent surgery, left lower lobectomy and left upper wedge resection, followed by 4 cycles of adjuvant chemotherapy. At the time, we didn't have an option of doing immunotherapy back in 2015 and 16. He was doing well, but then developed respiratory symptoms in 2019, and repeat imaging showed the left pleural effusion and pleural nodules and thickening is seen in the PET scan below. And he underwent a bronchoscopy, which showed the recurrence of lung adenocarcinoma. We performed further testing, and molecular profiling showed PD-L1 expression 50%, and then KRAS G12C mutation. And I'll get back to this case at the end of my presentation. So I will highlight 3 different approaches here. First, I will start by summarizing the data of anti-PD-1, PD-L1 monotherapy, followed by anti-PD-1, PD-L1 monotherapy inhibitor plus chemotherapy. And then in my last section, I'll discuss the double immune checkpoint blockade by itself or in combination with chemotherapy. So the first trial, and this is a landmark trial that I'd like to spend a few slides on because this is a study of pembrolizumab, which is anti-PD-1 inhibitor. And this was significant in the sense that this really changed the way we think about how to treat advanced non-small cell lung cancer without driver mutation. So here in this trial, patients with untreated stage 4 non-small cell lung cancer were included. And then their tumor had PD-L1 expression at least 50%. And then patients were assigned to either pembrolizumab, which was given initially for 2 years, as long as there was no progression or side effects, or platinum doublet chemotherapy, which was the standard treatment at the time. And the primary endpoint of the study was progression-free survival, and the key secondary endpoint was overall survival. And what was noted in the trial was that the response was better with the pembrolizumab in this patient population. The response rate was 46% with pembrolizumab versus 31% with chemotherapy. And what was also notable was that the duration of response with pembrolizumab was 29 months versus only 6 months with chemotherapy, establishing that pembrolizumab is a better treatment in that sense. But more importantly, it improved how long patient lived. So if the patient received pembrolizumab as their first treatment, patient lived about 26 months versus only 13 months with chemotherapy as the first treatment. And then the hazard ratio was 0.62, and this means that there was 38% reduction in the risk of death if they started the treatment with pembrolizumab as opposed to chemotherapy. The second trial I'd like to discuss is the KEYNOTE-042 trial, and this trial asked this question: can we use pembrolizumab, the PD-1 inhibitor, in a more broader way, expanding the criteria for PD-L1? And remember, in KEYNOTE-024, the PD-L1 requirement at least 50%. In this trial, which is very similar design to 024, the PD-L1 criteria was generous, at least 1%, and patients were either assigned to pembrolizumab alone or chemotherapy. And in this trial, the primary endpoint was overall survival, and they looked at different groups of PD-L1 expression and saw the improved overall survival in the overall patient population defined by PD-L1 at least 1%. However, if you look at the data a little deeply, and especially the PD-L1 expression 1 to 49%, there wasn't a significant benefit of pembrolizumab compared with the chemotherapy. And so in my clinical practice, I tend to use the combination of chemotherapy plus immunotherapy in those with PD-L1 less than 50% if they can tolerate the combination treatment. The next is IMpower 110 trial, where the anti-PD-L1 inhibitor called atezolizumab was tested and compared with the chemotherapy. And in this trial, similar findings were seen in those with high PD-L1 expression, defined by PD-L1 expression at least 50% on tumor cells or 10% on immune cells, had a survival benefit with atezolizumab versus chemotherapy, and establishing this as one of the options. And lastly, IMpower Lung 1 trial tested a PD-1 inhibitor called cemiplimab, and very similar design study compared with the prior studies where patients were randomized or assigned to two groups of treatments. Arm A was cemiplimab, which is PD-1 inhibitor, and then the second group was the chemotherapy. And in this trial, the hazard ratio for death was 0.57, again suggesting that there was 43% risk of reduction in death if the patient started their treatment with the cemiplimab versus chemotherapy. And the figure on the right is showing that if your PD-L1 expression number was higher and close to 100%, the better response was seen with the cemiplimab treatment, which is not surprising because cemiplimab is designed to target the PD-1, PD-L1 pathway. So the higher the PD-L1 expression was, the more benefit the patients drove. And this is showing the overall survival. This is updated data presented at ESMO 2022. And then the median overall survival with cemiplimab was 23.4 months, which is pretty close to the data that we saw in the KEYNOTE-024 trial with the pembrolizumab. And the median overall survival with chemotherapy was 13.7 months, and hazard ratio was 0.63, 30% reduction in the risk of death with the cemiplimab compared with the chemotherapy. And with these results, all these regimens were established as a standard treatment by the FDA with the FDA approvals. And really what it showed was that anti-PD-1 or anti-PD-L1 monotherapy has been shown to be superior to chemotherapy alone in patients with advanced non-small cell lung cancer harboring high PD-L1 expression.